Welcome back to Rebelcast. I'm your host, Salim Rizai, and this is Rebelcast episode 118. And today we're going to be talking about the PROCOAG trial. So this kind of slipped under the radar, but it's a trauma study that I think is worth discussing because I've seen rumblings of using four-factor PCC in trauma. So let's first start with, we know that hemorrhage is the leading cause of mortality in trauma patients. We know that things like hemorrhage control, giving tranexamic acid early, reducing the amount of crystalloid fluid volume that we're giving, using a balanced ratio of blood product transfusion have really helped improve and kind of move trauma resuscitation forward. Mortality, however, is still really high. And the number one reason or biggest reason is because of trauma-induced coagulopathy. And so I've heard rumblings on social media and from experts that maybe we should be using four-factor PCC. Now, there's very limited observational data on this. And just as a quick refresher, four-factor PCC contains factors 2, 7, 9, 10, as well as proteins S and C. So basically bringing a bazooka to a pistol fight. Now, it could help improve thrombin generation, which would then ultimately reduce blood product consumption and also maybe help improve mortality. But as I stated, if you're bringing a bazooka to a pistol fight, the flip side of that is that do we increase thromboembolic events? There's really no high quality studies on this. It's just kind of expert opinion and observational studies. And I'll just leave it at that. And as always, you guys know, my brother in crime, the Swami, is back. Swami, I am so glad that we're continuing to do these. It's always great catching up with you. And I think this is a good paper to discuss.
Absolutely. Great paper to discuss. I think trauma management is difficult, especially in the massively hemorrhaging patient. And so we really do need to look at how to maximize this. And one thing I think we have alluded to, but we just have to be clear about is this is not trauma patients who are on anticoagulation. This is all comers, all trauma patients who have massive hemorrhage or have enough hemorrhage, and we'll talk about the inclusion criteria, to need massive transfusion. So we're not just doing it for those patients who happen to be on a blood thinner. And I like the theory. I like the idea. I think we've become very enamored by PCCs because of the lab values that they kind of quickly reverse. But we really have to get some hard outcomes, some hard data telling us that this is better for our patients because these drugs aren't cheap.
They are not. And so the paper we're going to be talking about is Buzat P. et al., Efficacy and Safety of Early Administration of Four-Factor Prothrombin Complex Concentrate in Patients with Trauma at Risk of Massive Transfusion, the PROCOAG randomized trial, published in JAMA 2023. The clinical question they're trying to answer is, does four-factor PCC administration reduce 24-hour blood product consumption in adult patients with trauma at risk of massive transfusion compared to placebo? Now, Swami, we'll get into the nitty-gritty of this, but let's just start off with, what did they do in this trial?
This was a double-blind, randomized, placebo-controlled superiority trial. So this group did all of the things that we want to see, the double-blind, the randomization, but also added to this the superiority part. So really what they wanted to prove was not that four-factor PCC was as good as what we're already doing, but that it is better and we should all be embracing it. This was in 12 French designated level 1 trauma centers, and they looked at patients at risk for massive transfusion. They defined what they meant by at risk. They defined massive transfusion. We'll put all of that in the show notes so people can see it, but these were patients who were sick. This isn't your run-of-the-mill trauma patient with a little bit of bleeding who maybe needed 1 unit of PRBCs. These were sick trauma patients. At least that's what we should be focused on when we're thinking about this kind of an intervention. All the patients had restricted crystalloid fluid expansion. They all had early ratio-based transfusion of PRBCs and FFP in either a 1-to-1 or a 2-to-1 ratio. They all had IV tranexamic acid. They all had early hemorrhage control. Fibrinogen concentrate was given in all these patients if the fibrinogen level was under 1.5. And platelets were not given routinely, but they were given if the platelet count was low. So that was kind of the bundle of care that all of these trauma patients got. They were either randomized to get four-factor PCC 1 ml per kilo, placebo 1 ml per kilo, and that was given at 120 mLs per hour.
So let's talk about the outcomes here. So the primary outcome I've already stated in the question. Their efficacy primary outcome was median 24-hour all product consumption, and that includes red blood cells, FFP, and platelets. Not a patient-oriented outcome, but I do think it's important, especially in this day of running short on blood products. If we can reduce that, maybe that will translate to a mortality benefit. The important secondary outcomes were safety, were arterial or venous thromboembolic events, which is what I think most of us are worried about with four-factor PCC. And so that was defined as pulmonary embolism, DVT, stroke, MI, mesenteric ischemia, extremity that developed ischemia through 28 days. They also looked at the individual blood components. And if you look at some of the other important outcomes they looked at were number of ICU free days, ventilator free days, hospital free days, all the way through day 28. So Swami, who did they include? Who did they exclude?
These were adult patients who got trauma requiring transfer from the injury scene directly to a level 1 trauma center. So these patients went to an outlying hospital, were stabilized, and then transferred. They were not really included here, and they had to be at risk for massive transfusion. We'll put the exclusion stuff in the show notes. There's nothing really, I think, major here. If it was a traumatic cardiac arrest before randomization, they excluded that patient. But most of the other things, I think, are pretty reasonable reasons to exclude patients. Nothing that would really change the generalizability of this study.
So let's talk about the results here. So I'll get us started with kind of painting a picture of the population. So this was 4,313 trauma patients that got evaluated. That's a ton of trauma patients. 350 were eligible for emergency inclusion, 327 ended up being randomized, and then 324 actually ended up getting analyzed. So they really whittled that down. Now, as you said, Swami, when we look at the patient characteristics, this was a really sick cohort of patients. So median age was 39, injury severity score was 36, about 80% of patients had blunt injury, transfusion of greater than or equal to 10 units of blood products was about 27% of the population. That's a fourth of this population they were looking at. Admission lactate level was 4.6. That's millimoles per liter, depending on where you're listening from. Pre-hospital systolic blood pressure less than 90. 59% of these patients were coming in hypotensive.
Yeah, I like the group that they picked. Again, I think this is the group that we really care about. It's the group that's at risk for massive transfusion, that's pretty sick. And then when we go to their primary outcome, median 24-hour all product consumption, unfortunately, Salim, we don't really find much of a difference. In the four-factor PCC group, it was about 12 units. In the placebo group, 11 units. Absolute difference when they really whittled it down was pretty minor, and it wasn't statistically significantly different. So just to be very clear here, they did not find any statistically significant difference in the amount of blood components that were required for the patients, whether they got four-factor PCC or placebo. So they failed on the primary outcome. The secondary outcomes of interest, especially mortality, no difference. No difference in 24-hour mortality, no difference in 28-day mortality. And then when we go to that safety outcome, the one that we were already concerned about, we see more thromboembolic events in the four-factor PCC group, which again, not very surprising, about 35% in the four-factor PCC. In the placebo group, it was 24%. That's an absolute difference of 11%, and that was statistically significantly different. So at the heart of this, what we have, Salim, if we boil it down, is no benefit for reducing the amount of products that are going to be given, no mortality benefit, although that was a secondary outcome, and there was an increase in thromboembolic events.
Now, there were a lot of strengths and limitations. We're clearly not going to go through all of them. We'll list them in the show notes, but there's a couple that I wanted to kind of highlight, if that's okay with you, Swami.
For sure.
So the first thing is, we already said all the words we like. Double-blind, randomized, placebo-controlled superiority trial. I think if you're going to try and implement something, you don't want to see that it's just as good as, you want to see that it is better than. And so I really applaud the authors for doing that. There was no real changes to their protocol, which I thought was great. Now, this is kind of a nerdy stats thing, but after they completed their patient enrollment and before they analyzed the data, so that's important, before they completed patient enrollment and before they analyzed the data, the authors confirmed that the time spent in the study up to 24 hours did not differ between the two groups to prevent something called survivor bias for the primary outcome. And for those who aren't familiar with survivorship bias, or survival bias is the other name for it, it's just one of these logical errors of concentrating on patients or entities that passed a selection process while overlooking those that didn't. So how many people died early in placebo versus those that didn't? And then you try and compare those two groups and you end up with this survivorship bias because you forget about all the people that didn't make it. And so this can lead to incorrect conclusions because of incomplete data. And so I thought they did a really good job with that.
Yeah, this would be really important, Salim, if you saw like in the placebo group, a bunch of patients died very early, like within an hour. And as a result of dying within an hour, they didn't get a lot of blood products because they died before we could give them those blood products. The overall survivorship of the whole group, the overall mortality might be the same, but we just happen to see some early deaths that then biased the use of that blood products. And I'm not saying that's what we saw here, but this is how this could skew the data and not really give us the answer we're looking for.
Things that we always talk about, Swami, the groups were well balanced in terms of characteristics, pre-hospital vital signs, pre-hospital interventions, admission vital signs, admission labs, surgical radiologic hemorrhage control. Those were all good. Majority of patients, 95% of them received the study intervention that they were randomized to within the first hour of admission. And I really thought they did a good job with the pragmatic inclusion criteria so they could recruit as many of these severe bleeding patients as they could. Now, were there any limitations that stood out to you?
There's just a couple that I think are worth reviewing. We mentioned this already, but the primary outcome of 24-hour blood product use is not patient-centered. I think you and I would prefer to see mortality or significant morbidity that was avoided from giving four-factor PCC as opposed to just blood product use. Although, again, blood product use is an important outcome. It's just not a typically patient-centered one. The other thing that I think was kind of interesting is that we talked about that package of care that all these patients were supposed to get, but actually TXA didn't get received by everybody, and the rate of getting TXA pre-hospital was actually higher in the placebo group than it was in the four-factor PCC group. This is just how it happened, but I think it's interesting to note that. And then one of the things that you pointed out that really is going to depend on where you work is the use of viscoelastic testing. The transfusion or giving TXA or giving fibrinogen wasn't really based on viscoelastic testing here, which we do see some trauma centers moving towards, but not all trauma centers moving towards it. So if you happen to work in a place that uses viscoelastic testing, this study might not really apply to you because that's driving your use of either products or these things like factors and TXA and fibrinogen.
And then the last thing I want to mention is, although it was statistically significant, their safety outcome of more thromboembolic events, something important for people to remember is it's not like everybody was getting a CT pulmonary angiogram or everybody was getting ultrasound. And my point for that is that even without doing that in every single patient, they still found a statistically significant difference with more bad outcomes. And so what I'm saying is it was probably underreported.
Right. This wasn't routine screening.
Right.
It's not like everyone's getting the scan, everyone's getting DVT studies, which we have seen in some prior trauma literature where they just routinely did it on everybody to make sure they didn't miss anything. I like this approach. Let's do it based on clinical symptomology, whether we need to go down that route, but it is important to point out.
All right, let's move on to the discussion. So I'm going to just spend a little bit of time talking about the previous evidence of this because we alluded to it at the beginning of the podcast. So there's been 3 previous trials on four-factor PCC in trauma patients. 2 of them were observational trials comparing FFP only versus FFP plus four-factor PCC. And then there was a 3rd trial that was a single center open label trial comparing fibrinogen concentrate, factor 13 and four-factor PCC versus FFP. Now, all 3 observed a reduction in blood product consumption with four-factor PCC. And because they were observational, they can only say that there was an association, not causation, but they just weren't powered well enough to tell us about these thromboembolic events, which is why we're here talking about the PROCOAG trial.
This is really important that we get this kind of literature done, Salim. You know, I think trauma populations, it's a hard population to study. Critical patients, hard population to study. Combine those into one group, critical trauma patients, very hard to get a good, well put together, randomized, double-blind control trial. So kudos to these authors for doing the work. I'm sure that they wished that they found a benefit that we could then apply to patients going forward, but they were pretty honest in their conclusions. This is what they wrote, and we're just quoting them. Among patients with trauma at risk of massive transfusion, there was no significant reduction of 24-hour product consumption after administration of 4-factor PCC, but thromboembolic events were more common. These findings do not support systematic use of 4-factor PCC in patients at risk of massive transfusion. Could not be clearer than that.
I thought they were super honest, which is hard. Usually you're having to read between the lines or they're trying to push some objective. I felt like they were super honest. And I think our clinical take home point is kind of in line with theirs, is that in adult patients with trauma at risk of massive transfusion, receiving standard trauma resuscitation management, the addition of 4-factor PCC did not result in a decrease in blood product consumption over 24 hours compared to placebo. And additionally, the use of 4-factor PCC resulted in a higher rate of thromboembolic events compared to placebo. And so I think at this time, the use of 4-factor PCC is not really supported in patients with trauma at risk of massive transfusion. Now, with that, Swami, there will probably be future discussions about the use of viscoelastic assays and making decisions like kind of on an individual basis. But I think in terms of not having that information, which most places don't, this is not something that should be routine.
Yep, I think that conclusion is perfect. And it's so rare, Salim, that we get to just kind of repeat the author's conclusions because we agree with them virtually 100% here. And again, I'm not sure that the authors of this study are going to be listening to our podcast, but they really should know that this is the high quality work that our patients deserve. It is extremely hard to put together a study like this, and they did such excellent work in giving us a bit of an answer. And you're right, it's not the final word because things will change. But for now, this is pretty much the final word on this. I really don't think this should be routine use. It should be targeted, and who it should be targeted to is probably going to rely on the use of viscoelastic assays. Obviously, if the patient is on an anticoagulant, otherwise, I'm not sure that you're going to get much bang from your buck from this.
Couldn't agree more. All right, Rebel EM listeners, let us know your thoughts, comments, and questions. Thanks for tuning in, and until next time.